Hello everybody, and thank you for viewing our presentation on an overview of risk adjustment brought to you by Compliant Coding Systems Coding Academy. And so if you are here viewing this presentation, you were probably searching the internet or found a link or what have you. You're probably involved in the healthcare field in some way, shape, or form, and you probably were curious about risk adjustment in some way. And so we are here to share some of that information with you. Okay, and what we'll talk about is what is risk adjustment, and you'll meet Ozzie and Harriet, who will help us explain that. Who's responsible for risk adjustment, some practical examples of risk adjustment, common thoughts on risk adjustment, common HIM obstacles, that's health information management, obstacles to best practices, regulatory oversight, and how to improve overall performance. And you may see the AAPC CU approved logo there. Our program that we have is approved for continuing education units through AAPC, and AAPC is the American Academy of Professional Coders. And if you do need to contact us, you can contact us at ratraining@compliantcodingsystems.com. So before we meet Ozzie and Harriet, let's take a look at some fast facts. 50 million people are covered by Medicare. Of those, 14.4 million people are enrolled in what are called Medicare Advantage plans, and that's about 28%. Medicare Advantage plans are managed care health plans contracted by the government to provide health benefits for Medicare beneficiaries. By 2025, it's estimated that 73 million people will be covered by Medicare. There are hundreds of Medicare Advantage plans with enrolled members numbering from 1 to over 1 million. There's also over 55 million people who are on Medicaid, and that number excludes pregnant women because that is a constantly changing number. And over 70% of Medicaid enrollees are on Medicaid managed care plans, and that equates to about 38 million people. There's also hundreds of Medicaid managed care plans. Over 50 million people covered by risk adjustment models in Medicare and Medicaid alone. That does not even include commercial plans under the Affordable Care Act. And 17 states have over 80% of their Medicaid recipients in managed care plans. So just a few fast facts about Medicare, Medicaid, and risk adjustment. So I'd like you to meet Ozzie and Harriet. They're going to help us explain a little bit about risk adjustment. And they were on what is known as traditional Medicare Part A and Part B. Part A is your hospital stays and stuff like that, and Part B is your medical providers, your office visits with doctors and labs and stuff like that. So they were on Medicare Part A and Part B, and but they had options, and they elected to go with Medicare Part C or Medicare Advantage, and this is a commercial managed care insurance authorized by Medicare, and they elected to be covered under this option. It gave them that sense of insurance like they were accustomed to in their working years. So they no longer have Part A and Part B, and they are now covered by Medicare Part C, Medicare Advantage. And so now CMS, or the federal government, pays the Medicare Advantage plan a premium to cover Ozzie and Harriet. And they pay this premium, what's called a per member per month, or PMPM premium per month, just like we would pay if we were purchasing health insurance. Okay, and so the health plan uses that premium to pay for Ozzie and Harriet's health services in place of traditional Medicare. So just like traditional insurance, this Medicare Advantage plan is paying the doctor's bills, paying the hospital bills, providing at least the same benefits as Medicare Part A and Part B, and in a lot of cases, enhanced benefits. The health plan does not receive the same premium for Ozzie as they do Harriet, and we're going to take a look at why. Ozzie, he's rather healthy. He sees his physician once a year, and he has a pretty clean bill of health. He has no health conditions to speak of. So You know, that's Ozzie's situation. Harriet, she's a little different story, okay? Harriet, unfortunately has diabetes and uses insulin. She has COPD and requires oxygen. She has a condition called atrial fibrillation or AFib, and that requires anticoagulant therapy with regular monitoring. So you can see that Harriet is a bit more resource intensive, consumes more resources, and as you can see, she's costlier to cover than Ozzie is. So, as I said, um, the government pays the health plan more money to cover Harriet than Ozzie. Okay, and so CMS pays the health plan more for her premiums based on her health conditions. And so this is adjusting the premium due to her risk, or here we are with risk adjustment, adjusting the premium based on the risk of the patient or the health status of the patient. Okay. So how does Medicare know how much to pay the health plan? This is all based on documentation from her medical providers and the documentation that supports the conditions that she has. Okay. So does Medicare go through every patient's record individually? No. Okay. They do not. But medical coders do, and auditors do. Okay. And so these are specially trained medical coders. Okay. These are specially trained medical coders they're trained in risk adjustment guidelines and regulations. Okay, so let's talk a little bit about the guidelines and the regulations. They are set by federal regulation. They are overseen by HHS, or Health and Human Services, of which CMS, Centers for Medicaid and Medicare Services, is a division, and CMS administers this. However, risk adjustment is not just Medicare. It applies to commercial plans under the Affordable Care Act as well. So, so there's guidelines for all of them. But risk adjustment data, as I mentioned, comes from documentation with medical providers. And these guidelines, and this is just a part of them. This is certainly not a full course in risk adjustment, but some of the high points are it comes from face-to-face visits with authorized medical providers only. Okay, so it has to be a face-to-face visit with an authorized provider. And authorized providers would be MDs, medical doctors, PAs, NPs, that's physician assistants, nurse practitioners, DOs, doctor of osteopathy, DPMs, doctor of podiatric medicine. So licensed medical providers are essentially on the list of authorized medical providers. From certain service locations and source documents only, so we have to know where a treatment location is acceptable and what documents are. I'll give you an example. An X-ray report is not an acceptable document to be abstracting a risk adjustment condition from. These must be validated each year, and I'll use the example of somebody who's had an amputation, and you'll get pushback from providers who say, why do I have to document that? The patient has had an amputation 10 years ago. The limb is not going to grow back. Because that's the guideline. Must be validated each year. Must be supported in the record by monitoring, evaluating, assessing, or treating. Okay? It must be clearly supported in the record. Okay? And we'll see an example of this a bit later on. And it must meet other criteria, such as verified as a current condition. Okay. For example, a hip fracture will risk adjust, but a hip fracture is not a permanent condition, so it will only risk adjust while it is current. Okay. If the patient had a hip fracture 5 years ago and has healed, then it will no longer risk adjust. So these have to be verified, validated as current. Okay. So the medical conditions that get extra premium are subject to audit, okay? And the results may surprise you and they can be costly, okay? No medical provider likes to hear the 3 letters OIG. You can see this snapshot of reports from the OIG, and you'll see risk adjustment data validation, risk adjustment data validation, risk adjustment data validation, okay? So these are all health plans that have been audited and really called out by the OIG, okay? And so let's take a little closer look. And we're all in it together, providers too, the health plans, the health information management people, the providers, but the source for risk adjustment and the resulting revenue are from the providers, okay? So providers face static or even declining reimbursement, but they have some control in that, okay? And we'll look at that in just a moment. But here, this health plan, which I've redacted the name because I certainly don't want to call anybody out, but here is some information from one of those reports, and they are lengthy, so you know I pulled out what the really relevant information is here. And this health plan in Arizona submitted many diagnoses to the Centers for Medicare and Medicaid Services that did not comply with federal requirements, okay? And so we'll take a look here at the summary of the findings here, and you'll see that the summary of findings indicate that for 100 beneficiaries in the sample, 60 the risk score calculated using valid diagnoses. However, risk scores for the remaining 40 beneficiaries were invalid because the diagnoses were not supported for one of the following reasons. The documentation did not support the associated diagnosis, or the diagnosis was unconfirmed. Okay, and we're going to see examples of this in just a few minutes. The policies and procedures were not effective for ensuring the diagnosis that's submitted to CMS complied with the requirements. And then you'll see contracts required providers to submit accurate claims, okay? So again, the foundation is documentation from providers, and providers have a role here and a responsibility. So how are physicians impacted by their own documentation quality? Well, there's a number of different ways, and there's the full risk value-based reimbursement models such as ACOs, accountable care organizations, capitation, and in capitation where basically the provider gets a certain amount per month for each person on their responsibility list or their roles. The lower the operating funds in a plan, the lower the capitation rate. Shared risk, this is where practices receive additional revenue or share in the loss based on certain established performance measures. And many of these relate back to documentation. Fee for service, rates set for reimbursement depend on operating revenue, less reimbursement. So, you know, if you look at what a doctor charges for an office visit and what they will be paid, obviously, if there's not enough, you know, revenue, the office visits will be paid at a lower rate. And so when the insurance carriers set the rates, you know, they do that on a forecast of what their operating revenue is. So, and providers have the ability to impact that with their documentation. Quality measures are an ever-increasing reality in all aspects of healthcare, and physicians are impacted directly and impact other stakeholders, okay? So very important items here. And so just simply put, the medical record, the documentation impacts the revenue, the dollars, the funds available to provide care, okay? And quality is impacted if revenue is down. So so it is important, as you'll see, to have this documentation clear, concise, accurate. Okay, how? The patient here, we have a note. The patient presents for follow-up, and it says that the patient is following up for labs and hypertension and shortness of breath. Okay. It is unlikely that a patient with multiple chronic conditions would be followed up for only one, yet only one is mentioned or addressed here, okay? A little later in the note, there's a passage or an entry here. He was told he had emphysema that might need to be treated, but he denies any chest pain or shortness of breath at this time. And then there's a passage, his blood sugars have been more stable. He has tried to watch his diet and exercise. Okay. Now I do call your attention to the highlight down there on this medication list. There is metformin, which is a prescription medication prescribed to diabetics. Okay. But I'm going to I included this portion of the note. The whole note wouldn't fit on one slide legibly, so I did include the middle section where the physical exam is for the integrity of the note and completeness sake, but there's nothing here that will impact code assignment. So let's look at the bottom half of this slide first. You'll see the diagnosis, and you'll see a code and then an entry, and it's 414.9 coronary artery disease, 250.00 diabetes, and 492 emphysema. Okay, plan, follow up in 1 month. Okay, and we'll come back to that. But for anybody who works with this, works in this environment, you know, anywhere with records and claims, you will likely recognize that this was not a doctor typing in that code and that description. They picked it off of a selection list on a computer. Okay, and this is one of the documentation quality issues that is very, very common and very problematic. Q1 2012 coding clinic, and we'll talk about coding clinic in a minute, ruling on physicians using a diagnosis code in lieu of a written diagnosis. Coding clinic was asked about physicians choosing a diagnosis code in an EMR, electronic medical record, versus using a written diagnosis. One important point that coding clinic refers to is a very common practice that is not acceptable, and that is providers selecting the diagnosis code and short descriptor of the code and using it as an assessment. So what coding clinic states is it is not appropriate for providers to list the code number or select a code number from a list of codes in place of a written diagnostic statement. ICD-9-CM is a statistical classification per se. It is not a diagnosis. It only classifies diagnoses. Okay, so coding clinic, which we'll see a little bit more about in just a moment, has indicated that this is not correct. Now, if you're watching this and you are somebody who is familiar with coding, one of the things that you may recognize is that 414.9 is not even a complete diagnosis code. 414.9 would require a 5th digit. Okay. Also, there was absolutely no mention of coronary artery disease. There wasn't even alluding to coronary artery disease. Okay, at least the diabetes, we had some vague reference of some symptoms, some circumstance, but it was not definitively stated. But the coronary artery disease, there's just nothing there, yet it has been assigned here, and that is just improper. Okay, so we were talking about coding clinic. What is coding clinic? Coding clinic is the extension of ICD-9 and ICD-10. It's the authorized resource to provide guidance and clarification on ICD-9 or 10. There's a long-standing circumstance where ICD-9 and ICD-10 guidelines are not followed closely in outpatient settings, locations of service. One reason is that a fee-for-service and capitation do not often trigger claims denials unless there's a significant disparity, such as billing an X-ray of the ankle with a diagnosis of headache. Okay, an EKG with some non-specific code like hypertension unspecified would likely be paid. You know, even though the diagnosis or diagnosis code could be more specific. So Um, when it comes to coding clinic, the other obstacle is that a lot of coders, when they're trained, just are not trained on coding clinic, and also it is an annual subscription that is in the $300 to $400 range. And although coders have to buy their diagnosis books and their procedure books every year, and another manual called HCPCS, for some reason there is a widespread epidemic of coders not purchasing Coding Clinic and not being aware of Coding Clinic. All I can say is that if somebody gets pulled over for speeding and tells the officer they didn't know what the speed limit is, they're still likely to receive a speeding ticket. Okay, so not having access to Coding Clinic is not an excuse. And as indicated in the following passage from CMS, Medicare Advantage Participant Guide, which is the resource for guidelines for the Medicare Advantage plan and therefore the risk adjustment, AHA Coding Clinic is official guidance and governing. Okay. And you'll see here, to assist the users of ICD-9-CM in interpreting and clarifying the guidelines, as well as publishing updated codes and applications, the AHA, which is American Hospital Association, central office on ICD-9-CM and now ICD-10-CM, publishes quarterly official code advice in Coding Clinic for ICD-9-CM and as well ICD-10-CM. The Coding Clinic for ICD-9-CM is the approved resource to update and clarify the use of ICD-9-CM. The small volumes, typically about 20 pages, include clarifications of previous advice and guidelines or new information on specific diagnosis coding practice by means of articles and a question and answering section. So that discrepancy, that deficiency in the documentation where we showed that there was a coding clinic guiding that is binding. That is official guidance, and it guides that scenario. Okay. So that note that we looked at, the likely audit result would be failure. Okay. Coders and auditors cannot make medical judgments or clinical decisions or conclusions. Documentation states follow-up for hypertension. It does not state the diabetes is not stated by the provider. The emphysema is documented as documented is questionable, and we'll talk about that more in a minute. CAD is simply not indicated in the documentation at all. It's not monitored, evaluated, addressed, or treated. Nothing. Okay, so this note would be if those conditions were submitted to CMS and reviewed on audit, this would be a note of utter failure. Okay, let's look at what the typical provider rationale would be. Okay, the rebuttal would be, okay, the physician would likely state, well, but the patient is on metformin and the blood sugars have been more stable, and that's documented. Well, the fact is that would require a chart reviewer to interpret that data and make a medical conclusion. That is unethical and out of the scope of practice of anyone other than the treating provider. Okay, so the provider would have to state the diabetes. Okay, we can't make conclusions based on signs or symptoms or medications. The emphysema is mentioned would be another provider rationale. Well, yeah, the word emphysema is mentioned, but the fact is the documentation states third-party information from the patient, and the statement might need to be treated indicates a possible or a rule-out diagnosis or an unconfirmed diagnosis. A patient with emphysema requires treatment. There is no stated diagnosis from the provider. Okay, the use of the word is in relaying information the patient was told. Okay, not a statement by the treating provider in that encounter definitively stating the patient has emphysema. CAD, there's simply no documentation to support this other than perhaps the aspirin on the medication list. And again, a coder or auditor cannot assume or make a judgment as to what a medication is prescribed for, even over-the-counter meds, and simply there was just nothing in that record to support that CAD, that coronary artery disease diagnosis. Okay. So the ultimate reality, providers need to accept and even embrace that the medical record is a legal document with established industry guidelines and even regulations that must be adhered to. There are many stakeholders in a record and the manner in which it is documented. And there are some providers that seem to feel the documentation is for their own use and their own use only. Um, we're going to demonstrate that that's not the case, okay, on the next slides. CMS guidelines on documentation, and this is the guidelines for E&M, or evaluation and management services, which are typically your face-to-face visit, usually in the outpatient, the office visits and stuff, but there are inpatient as well. And so let's just take a look at these things in red. CMS states that the medical record documentation for all E&M services is appropriate if the medical record should be complete and legible. The documentation of each patient encounter should include the reason for the encounter and the relevant history and findings. It should include assessment, clinical impression or diagnosis, and a plan of care. I will tell you that most providers, I'd be surprised if we could find a provider who doesn't know what a SOAP note is. I believe they teach it in medical school. It's the typical flow of an encounter. It stands for subjective, objective, assessment, and plan. Okay, and so simply stating a diagnosis is not sufficient. If a diagnosis is made, then a doctor needs to indicate what they're going to do about the diagnosis, how they're going to address it, how they're going to treat it. Okay, and clearly that was absent in the documentation we looked at. Date and legible identity of the observer. These are some other things. Again, we're focusing on the things in red. Appropriate health risk factors should be identified. The diagnosis and treatment codes reported on the health insurance claim form or billing statement should be supported by the documentation in the medical record. Okay, so again, it's all about documentation. It's all about putting it in specifics and in black and white in the documentation. Additionally, most physicians have hospital privileges and document in hospital records. Okay. And federal law states, this is CFR 482.24, conditions of participation for hospitals in the Medicare program. And folks, this is federal law, okay? And this is not the complete regulation. Obviously, that wouldn't fit on one slide. So please, I ask you to indulge me that I did include relevant information and didn't exclude anything that would refute this. Again, the important parts here are records need to be accurately written, okay, promptly completed, properly filled and retained, okay, and then content of the record must contain information to justify, support the diagnosis, and describe the patient's progress and response to medications and services, okay. Clearly, in the record we looked at, that was not accomplished. And, for providers who, see patients in the office and in the hospital, it just simply wouldn't be reasonable to practice one documentation standard in one location and a different standard in another location. And typically what you find is that the documentation in the hospitals is often a bit on the weak side as well. So I've been in this business over 25 years, and here are two resounding things that I've heard from providers. A, I didn't go to medical school to be a scribe, and the other, I'm a doctor, I treat patients. This is all about the money. My job is to treat patients. Okay. Well, the reality is when it comes to this thing called risk adjustment and documentation, if the clinical documentation is as specific, clear, and accurate as it can be clinically, then this wouldn't be about the money. In fact, it is about providing the appropriate resources to provide quality of care for conditions that exist. Okay, and so that is clearly clinical and quality driven. The resources are based on the clinical circumstances of the patient. Therefore, it is firmly based on the clinical treatment of the patient and not about the money. Okay. The second part about this, and I don't want to be beating up physicians, or they're fantastic people, incredible people, every one that I've ever met. Just what they deal with in responsibility, I can't imagine a loftier burden. But becoming professional in any area is about being thoroughly expert in a field. And it's not the trait of a professional to choose the aspects they favor or exclude the aspects they do not, which is a common problem when it comes to documentation. And just a note about money. One of the most common definition components in a majority of dictionaries includes this: one whose income is derived from the practice of his or her profession. And while there are a few exceptions, the majority of physicians and other medical providers practice medicine for their income. So let's turn the page on the whole it's about money argument. Between complying with all laws and regulations, as well as receiving correct compensation or receiving the resources to deliver appropriate and quality care, okay, health plans have a great deal of responsibility. Okay, so physicians have a lot of responsibility. Health plans have a lot of responsibility. We all have a lot of responsibility. So remember that slide. This in the medical record impacts this, the revenue and the dollars, the resources to provide that level and quality of care. The health plans need you. The system, the whole industry needs you. And you means the clinicians, the coders, everybody working together to make this process work. Okay. And so we're all in it together. So that is an overview of risk adjustment, and again, that's brought to you by Compliant Coding Systems Coding Academy, and we'd love for you to join us for complete risk adjustment training. Again, you can contact us at ratraining@compliantcodingsystems.com, and let's talk about a little bit what's covered in the program. We cover ICD-10 guidelines, okay, those guidelines that direct documentation and instruct what is appropriate and what is not appropriate or sufficient. Correct ICD-10 CM code assignment, okay? So you don't have a truncated code or an inappropriate code. Risk adjustment models. There's the Medicare risk adjustment model. There's several different models that apply to Medicaid in different states. And then there's, of course, the commercial risk adjustment model. So we look at all the different models and get a sense of similarities and differences. Risk adjustment guidelines. We talk about the guidelines for risk adjustment, and we talked about a few of them here. And we look at what the guidelines are, how they're to be applied, and pitfalls of documentation or processes not measuring up to guidelines. We talk about documentation. We look at records such as the one we looked at here, and we identify either deficiencies, missed opportunities, areas of improvement, or we praise good documentation. We talk about compliance, and that is a very broad term, but anything where there is a rule, regulation, a guideline, and it is not followed appropriately, that is a compliance issue, and we talk about that. Quality measures in risk adjustment, and the two most common are HEDIS and STAR, and they are the most relevant to risk adjustment, and we look at those in depth. Data collection, submission, and adjudication, including risk score factoring. So we dissect how information is gathered, where it's gathered from, how it's assembled and submitted, how it's adjudicated into the system, and then how it's audited as well. And we look at how a risk score is arrived at, and that's a hierarchical structure based on general condition categories and then ranking conditions within a category. Okay. We talk about how providers can leverage their best practices for incentives, and a lot of practices, a lot of professionals are now being held accountable for um, either um, positive impact or negative impact on revenue based on risk adjustment, and we talk about how providers can use this to their advantage and how they are incentivized these days. For HIM professionals, we talk about career paths and the wide variety of opportunities. And yes, we have an MD on staff that is part of the training. So why would you choose Compliant Coding Systems Coding Academy? Well, there's a few entries here. Please feel free to read them. Although I feel like although I've done HCC coding, only now do I feel I've had the appropriate training. There's some other nice comments here. Please, feel free to take a moment to read these. But the one in red is the one that I feel I believe in the quality of our program. I helped author the program. I'm a very seasoned expert in the industry and in the subject matter. Um, but the quality I'm very proud of. Um, but the next slide will demonstrate probably the thing I'm equally proud of. And these are real numbers, folks. This is a comparison of cost for training. Uh, Course A is $11.95, almost $1,200. Course B is $12.97, almost $1,300. Course C is $19.95, almost $2,000. And folks, Compliant Coding Systems, Coding Academy, risk adjustment training is $299. Okay. Um, it is inexpensive, but folks, I will tell you that it is the best in the industry. And there's plenty of unbiased people who have said this as well. We offer CEUs up to 20 possible, okay? Um, we offer 2 live web conferences per week for 1 year as a standard part of the package. One is a certification study hour for those seeking certification. Each week we dissect some element or domain of the exam and answer questions, okay? The other is a weekly practical chart review where we go through charts just like we did here in this presentation, and we go through and we look at the documentation. We identify conditions that could be reported, and we identify deficiencies, okay? And we do this so that everybody can remain as proficient or become as proficient as possible in identifying validated conditions. We have a highly experienced team of risk adjustment professionals, veterans with many, many years of experience that also have attained this certification, okay? So we have one of the best teams in the industry. We have an option for discounted access to the CDI forum, which is a clinical documentation improvement series that's offered twice a week. Okay, and participation in the risk adjustment program gets you access to that at a highly discounted rate. We have an MD who is also a CDIP, that is Clinical Documentation Improvement Practitioner. It's another certification. The MD is our Chief Medical Information Officer, and he is on staff and involved in the training. Okay, and our content, as I mentioned, is the most comprehensive in the history in the industry. Okay, it is as detailed as any content. It is as comprehensive as any content. I can assure you it is written by seasoned veterans who know every nook and cranny of this subject matter. Okay. Our training is used by numerous Medicare Advantage plans for their staff, as well as chart abstraction vendors. And here's a kind note. I use Doug Palmer's material to instruct my staff. I'm happy to report 100% of my staff now hold the credential CRC. I highly recommend Compliant Coding Systems Risk Adjustment Boot Camp. So a very nice comment from one of the executives at one of the health plans that has used our training. And finally, there's just more resources, more tools, more mock exams, and more support than any other program at 5 times or 6 times our cost. Okay. Couple final reasons why you would choose Compliant Coding Systems Coding Academy. Well, for coders, you get to add a very valuable credential. If you already have a credential, then being multi-credentialed is always a very positive thing. If you are a new coder or just learning coding or perhaps taking a course, you can go ahead and get your first credential sooner and without any apprentice or probationary status. Okay, you can add to your skill sets and marketability, and you can just grow as an industry professional and expert in a very very prominent area of health information management, revenue cycle, and clinical documentation. For medical administrators, understands the detail and in detail processes that impact your bottom line. To a lot of medical office administrators, these processes are transparent to you. You may not even know they exist or may not even know how they're affecting your bottom line, but by completion of the course, you will. You'll understand the potential compliance issues that could impact your practice. Okay, and you'll be better positioned for managing medical records from a clinical perspective optimally. And for clinicians, you will, of course, get the benefit of understanding all these guidelines, and understanding them will go a long way for you in your daily practice. I can assure you it will increase your quality of care, both the way you deliver care and the way your quality is measured by industry standards. Okay, so you will achieve higher quality measure performance. You'll understand the common goal of documentation. Okay, so there's sometimes a push and pull relationship between HIM, Health Information Management, revenue cycle, and clinical participants. Okay, but we all have the same common goal. And when we understand what those common goals are, it's easier to reach those goals. And again, as I mentioned, we have Dr. McKinnon, our Chief Medical Information Officer, and he is available to speak with clinicians, and you can interact with an MD on these clinical documentation matters. He understands your perspective, and he may be able to sway you into a better position from a clinical documentation perspective. So those are the reasons you might want to choose or consider Compliant Coding Systems for your risk adjustment training. And it just wouldn't be proper to finish this without revisiting Ozzie and Harriet. How are they doing? Well, thanks to the work of their medical providers, or hardworking medical providers, the HIM professionals that are part of the process, and their health plan, Ozzie and Harriet are getting the highest quality care possible and doing well. We're happy to report. So please do contact us, ratraining@compliantcodingsystems.com, should you have any questions or interest in a full risk adjustment training program. We have the best in the industry, and we look forward to sharing that with you. And we thank you for taking the time to listen to the presentation today, and we hope to see you again real soon. Thank you, everybody.